Good afternoon, good morning, or good evening, dear colleagues, wherever you are. This is a webinar from the European Society of Intensive Care Medicine on silent ICU management. I'm delighted to co-chair this webinar with Dr. Victoria Metacha, who is an ICU specialist and consultant at King's College Hospital in London. And everyone knows Victoria, who has a specialty focus on ICU hematology patients, end-of-life practices, and medical ethics. We are going to have two very important speakers. Both are past presidents. Professor Maria Cruz Martin Delgado from Madrid is the head of the department of the ICU in Universidad Complutense in Madrid. She is the president of the Federation of Pan American and Iberica Critical Care and Intensive Care Therapy, and she's the past president of the SEMISUC. And Professor Kesesioglu, who is the past president of the European Society, who is professor of medicine in critical care medicine at the Department of Intensive Care Medicine in Utrecht, in the Netherlands. And he has been chair of the ethics section, and he has, as you all know, a very important interest in RDS, in selective decontamination of the digestive tract, and in medical ethics. Over the last years, there have been a rising interest in new outcome variables in the ICU. We are going much beyond mortality, much beyond morbidity. We have described the post-ICU syndrome with an international effort of describing symptoms in patients and in family members. And sometimes it's much more than only physical sequels. It's also about emotional sequels or sometimes mental health symptoms. Dr. Metacha, Victoria, you have recently co-authored an important review article on this topic. Can you tell us more about these new outcome variables and this gaining interest for patients and family members in the ICU?
Thank you, Professor Elian, for the introduction. And it's really exciting to be here in this webinar. So yes, we co-authored a paper, and we started after a roundtable we had, didn't we, in Lives 2021 that was sponsored by GE. And I mentioned this because we made a real effort to include industry into this, mainly to show that experience for our patients, for our families, but also for ourselves is very, very connected. It's very much connected to industry and to technology. And I think that it was very interesting for me to see that the topic of experience in ICU from the very different aspects, wasn't it? From the patient aspect, first of all, because it's the patient that experiences discomfort in ICU. And in the very nice, if I have to say so myself, paper of critical care, you do see the various topics and the various issues that a patient faces in ICU, not just because of the noise, of the lines, of the pain and the hunger and thirst they experience, but because of the isolation, the fact that they don't understand all the information and they can't speak. And I think this is where artificial intelligence and technology can come in to help our patients and enhance communication. So this is just one aspect of how technology and artificial intelligence can help us in ICU. In the paper, we also looked at the aspect of the family, right? Because, and when we saw that about 20% of the patients and then family members will experience PTSD after discharge from ICU. We discussed and we thought about how we could humanize ICU a bit more by increasing visiting, excuse me, by extending visiting hours, by having specialized help, social workers or psychologists that could help. Of course, Ali, I'm sure you know, evidence is not very clear about how effective these interventions are, but nonetheless, we discussed about them. And the third thing we looked at, the third aspect, was how we can increase experience for ourselves, for the healthcare professionals. And we know that, especially after the 2 horrible years, we're all a bit broken, and we all can use all the help we can get. So we looked at how we can increase our own comfort in ICU by using technology. So maybe digitalizing ICU, digitalizing the notes, not having to go through pieces of paper or having to order on paper or having to call departments. And this was proven to reduce the workload and increase our satisfaction and our way of working. And I think that's a very good summary. And we came up with a few suggestions in each category. And I think we left feeling that I don't think we should be at odds. Industry is not the enemy, is it? I think they should come, and technology should be incorporated in our everyday practice. That's me.
Yeah, that's a very interesting link between how we can collaborate, and this webinar is sponsored by Mindray, how we can collaborate between industrial partners, ICU specialists and hospitals to not only produce devices and ways to improve the patient experience, but also sometimes to offer a monitoring that delivers a new way to alert the healthcare providers without harming. Because as you just mentioned, I think your point is very, very true. Noise is painful, and noise provides a very, very bad memory for after the ICU. And this is really part of the things that are going to contribute to the post-ICU syndrome. One of the major syndromes after the ICU, as you said, is post-traumatic stress disorder that affects 1 in 4 patients and even more family members. And we don't know so much about it. We know some risk factors, but we need to better understand how we are getting there. Let's now start the webinar itself. Thank you very much, Victoria. And I'm delighted to introduce Professor Maria Cruz Martin Delgado from Madrid on patient stressors in the ICU, quality indicators and recommendations from the literature. Thank you very much, Maria Cruz.
Good afternoon. Thank you very much, Dr. Azulay, for the invitation of participating in this webinar and to the European Society of Intensive Care Medicine and of the people who are connected in this webinar. In the next minutes, I try to speak about patients' stressors in the ICU and how the quality indicators can improve in this ambit. I have no conflict of interest in this disease. Only I could become an ICU patient or relative in the next time. The objective of the ICU is ensuring the highest quality of care in all its dimensions. And we know the intensive care unit is a therapeutic place for monitoring critical ill patients, and the modern ICU are equipped with high advanced technological machines and equally skilled professionals who strive to provide effective, high rational and individualized care. The ICU shines at the same time that it provides integral care of high complexity to the several patients. It generates stress in the patient due to physical discomfort, but also physiological disturbance caused by physical structure, equipment, alarms, noise, luminosity, key movement of the people, withdrawal with the environment, confrontation with the suffering, and the possibility of death. We can describe the stress can be understood as not adapting the individual to a state of permanent imbalance, and the response to stress is a physiological condition where chemical and electrical reactions of the nervous system trigger a series of organic signals that reveals this exposure, such as elevated blood pressure, increased glucose, cholesterol, palpitation, among others. And we know that prolonged exposure to stressors increase the possibility of disease development. I think this paper, ICU, a branch of health, is very in interesting to introduce this talk. An interview on national television with a recent celebrity. In months ago, this person had sustained extremely serious life-threatening injuries in a traffic accident that had led to a prolonged stay in the ICU. And when the show host asked her about her experience and memories of those dramatic moments, the interview defined the ICU as a branch of hell. This person supported her statement with the following reason. When she awoke in the ICU after being in coma during about 2 weeks, she relayed, the problem is not the pain and the fear are. Sometimes the fear is worse than the pain and the combination of fear with pain. There was a time when I thought I was dying, and above all, there came a time when I already wanted to die. I think this experience of a patient in the ICU can illustrate the importance of the stressors factors in the ICU. Almost all patients experience one or more uncomfortable symptoms in the ICU, and they are defined as an individual subjective negative feeling which encompass physiological and psychological symptoms. The hypothesis were these stressors are perceived individually according to the context they present. So from their identification, it is possible to act on these factors, adopting measures to promote the humanization of care. ICU are stressful environments for patients, and we have a lot of studies which report that patients follow up in the ICU are exposed to high levels of stress. These interrelated environmental stressors negatively affect patients in intensive care experience, and perceived stress can by itself be regarded as a negative patient report outcome. Stressors in the ICU is associated with worse mental health and cognitive outcomes during and after intensive care, including the respective domains of the post-intensive care syndrome. And factors causing stress in the ICU lead to the emergence of sensory change, such as sensory overload, sensory deprivation, and perceptual deprivation in patients, and the development of intensive care syndrome. There is extensive research available on stressors and stressors experience of patients in the ICU, and major findings have shown that the stressful experience of the ICU patients are, and this is very important, multifactorial. Among the main causes are treatment procedures, physical stressors, illness-related impairments, environmental factors, as well as associated mental distress. We know there are a lot of stress factors in the ICU: catheters, drains, mechanical ventilation, treatment and care interventions, aspiration, dressing change, position change, rehabilitation practice, noise, insomnia, pain, inability to communicate, lack of family support, the presence of tubes, lines. There are the factors that create stress in the ICU patients, and we can measure of ICU-related stressors, but we don't do very frequently. We have scales and questionnaires like intensive care unit environmental stressor scale and environmental stressors questionnaires to know the stress factors to the patients, which is the level of these discomfortable symptoms. This is a recently systematic review with inclusion 42 prospective cross-sectional quantitative observational studies, and the authors can show us 137 stressors items that were most frequently ranked among the most severe stressors in 4 domains: physical treatment and disease-related stressors, communication, mental health, and environmental. And it's very interesting to look at these factors. No? There are a lot in the 4 domains: physical treatment and disease-related stressors, like the most important for the patients being in pain, pain of discomfort associated with ETT, being thirsty, short of breath, pain and discomfort anticipate of result of treatment, and explain procedures. the authors in this study speak about 17 communicators stressors. The high punctuation are not being able to talk, not being able to communicate, not knowing for sure what illness the patient have, not being told which is the diagnosis, or not having treatment explained to the patient. Environmental stressors are well being known. Hearing other patients cry out was upsetting to see what happened to other patients, alarms, excessive light, noise, watching treatments being given to other patients, limit visit hours, and especially 41 mental health stressors. The most important, fear of death, thought I will die, spell or terror panic, fear, being worried, feeling something bad will happen, or knowing that you have a serious illness. It's important to know the patient perspective. In this study, the stressors ranking list of the three groups, patients, relative, and healthcare professionals, consisted of rather similar items, and the list of healthcare professionals and relatives did not contain any stressors that were not included in the list of the patients. But the patients have another perspective, and they talk about shortness of breath, frequent interruption of sleep, nightmares, bad dreams, feeling helpless, depression, not being told what your diagnostic is, dependence on doctors and nurses, or having doctors and nurses talk about you rather than to you. And it was upsetting to see what happened to other patients. In this part, healthcare professionals and relatives seem to concordantly overestimate the general stressors intensities. However, there are also research finding that show that healthcare professionals sometimes underestimate negative and overestimate positive experience of the patients. During the last years, ICU standards have improved, and chances of survival after critical illness have increased, but say that these changes are not changing the core stressors in our patients. Despite technological change, the stressors factors have not changed during these years. And another thing is several studies found that between 15% and 38% of the ICU patients did not remember their experience on ICU, and about 50% had difficulties to distinguish dreams and reality. And this means that the stress perception of this considerable large group of the ICU patients could be underdiagnosed. The last years, we have different moving of projects that who has the goal to improve the humanization in the intensive care unit. And the Proyecto Humanizando los Cuidados Intensivos is a project multi-professional and international who has worked in this area, working in different aspects in the with the patients, families, and professionals and healthcare professionals. This was the basis for the plan of humanization of intensive care in the community of Madrid. And in this plan, we work in define the activities, but not only the quality indicators, the standard, regularity, and responsibility of all the healthcare professionals. The project, El Proyecto UCI has worked so in a manual of good practice to humanize the intensive care unit and define 160 good practice to guide the healthcare organization and professional to improve quality of work through certification, and all this strategic line can improve the well-being of the patients. This is only an example about physical well-being, promoting measures that avoid of decreased physical discomfort and favor early motor recovery. Another about environmental well-being and nighttime rest, control environment noise and light and nighttime rest measures, the volume of the alarms, and interventions adapted to the rest periods in the ICU, quality of the sleep, and different interventions like musicotherapy that can be improve the environmental well-being of the patients in the ICU. We promote another actions related with the psychological well-being, like use of entertainment medias, interventions to support of patient spiritual needs, the presence of the psychology as part of the healthcare team, and work outside the patient when they can benefit from it, or the possibility to self-care to improve the patient's self-perception. And in this part, we have a good practice to promote patient autonomy, like control walking, use bathroom, regular use of mobile phone, indication for self-care or occupational therapy. But one of the most important thing is try to communication with the patient, because we know there are a lot of patients with have problems to communication with the family and with the teamwork. It's necessary to use augmentative and alternative communication systems and training to the professional to use this technology to improve the communication in the patients with problems with the talk, because they are in mechanical ventilation or have another illness. The Spanish Society has worked in this objective with the quality indicators, and this is update. The last update was in 2017. The main objective of this was to provide healthcare professionals and managers instrument to analyze the appropriateness of care of critical patients and identify important aspects to clinical practice. And we have a lot of indicators like use of restraints in the patients. We want to reach 0 restraints in the ICU. Work to reduce the isolation in the patients, and it is possible with flexible visiting hours. This is important decision between family and caregivers with social visitors, and we have enough evidence that the family visitation in the ICU can reduce outcomes like anxiety, depression, trauma stress disorders, and other outcomes. Pain is one of the experience, one of the physical stressors more important for the patient in ICU. More than 30% of the ICU patients experience moderate to severe pain, and it increased during common care procedures. And pain is associated with discomfort, sleep deprivation, and increased morbidity, mortality, and length of stay. And we have indicators that how to monitor pain in patients who can communicate, but also to patients who cannot communicate in the ICU. It's important to measure measure the delirium and have strategies with non-pharmacological prevention of these important symptoms in the ICU. Noise is, the one of insidious important environmental stressors, and the technology in this part can improve the level of the alarms and the noise in the hours units. And the inability to sleep, insomnia is one of the most important patient stressors in the ICU, and there are a lot of activities for patients' sleep promotion, like noise reduction, use of the earplugs or AMAX, music, control of the pain, wait time, or promote circadian rhythm, or another aspects related with the ventilation technique. We are speak about thirst, one of the most intense and unrecognized and undertreated symptoms suffered by critical ill patients. The prevalence in the ICU is about 70%, and we have some tools to use to interventions, banners that can use to improve this stress factor. And we have another things, music-based interventions is one of the most common non-drug treatments used by clinical staff and can effectively alleviate multiple uncomfortable symptoms. And another possibility that is becoming more and more frequent in our ICU, taking patients outside the unit. We can work a lot with the recommendation to improve the well-being of the patients in the ICU, not only with the patients, the families, and the stressors will affect to the healthcare professionals. And inability to speak is a barrier to the patients to communicate these stressors and their needs. We have tools like this ICU patient communicator and another similar that can help us to know what is the situation of the patient, what are the needs of the patients, and we need to use this in the clinical practice every day with every patient, because the evidence shows that the feasibility, utility, and safety of communication interventions with mechanical ventilation patients in our units. But if this is the end, we not only focus in the negative aspects of the intensive care, like the safety to model of the safety patient theory, we can improve focus in the success, the situation, or the analysis who show us the positive experience of the ICU patients and not is habitually in the practice. We need to know which is the perceived quality of discharge from the ICU, not only the ICU, only discharge of the hospital. And my conclusion in this way were first, assessment and support of patients' well-being must be considered as a key element of the quality of care. Second, warranty professionals have appropriate training and promoting measures to deal with or mitigate patients' stressors in ICU to ensure patient well-being are the main goal when caring for critical care. And the last, ensuring effective communication is essential to reduce the stress of ICU patients. Thank you very much for your attention.
Professor Delgado, thank you. Thank you very, very much for that. That was a very comprehensive, that was a very stimulating talk. I think you touched on a lot of topics, and I'm sure we will be able to discuss. We will take questions at the end, so please make sure you post all your questions for our experts. I'm sure I know I have a few questions, and before I move on to Professor Kesesioglu, I just want to say it's quite remarkable that you can do this, or I will ask you if you could do this across your Spanish or ICUs. I think that's quite impressive. But let's keep that for last. And without further ado, I think I would like to introduce Professor Kesesioglu, if he requires any introduction. A professor in intensive care medicine in Utrecht, a past chair of the ethics section of the SICM, and many other positions, but of course also a past president of ESICM. Joseph, over to you if we're ready. Thank you very much.
Thank you, Victoria. I was afraid that the introduction would be as much as my presentation, but thank you for the very nice words. I will now actually start with a statement as the core principle of an intensive care unit, that ICU is a semi-autonomous mini hospital. You may like this. If you are a hospital manager, you may dislike this. You may agree with this. You may completely disagree with this, but I will just start with this because we all know that we have a unique work algorithm, which is completely different than most of the parts of, or maybe even all of the other parts of the hospital. I will just go on with other core principles that we are constantly confronted with a balance keeping necessity, and the balance keeping is keeping the balance of innovation, functionality, the space that is available for us, our limitations concerning the physical limitations or the financial limitations. And we need to balance that all the time with making a healing environment for our patients, for the staff, for the visitors, and a secure environment. And that's why we also need to have the ICU equipments and supplies. If we look at the recent developments, and when I say recent, I'm actually talking about the last 15 to 20 years. It's quite a long recent concept. More and more insight is developed on the mental stress of the patient and the family. In the past 30 years ago, 40 years ago, we were thinking that the patient or the family should be only very happy if the patient was leaving the ICU alive. Now we know that that's not the only norm that we have, also mentioned by the previous speaker. And we also are very careful with the well-being of our personnel, who are also very scarce, and we are very much aware of the safety procedures in order to avoid unwanted effects. I will just today talk some possible innovations, but I just thought that I can divide them into technological and natural ones. Technological are easy to, I mean, it's a self-explanatory word. The natural ones are the innovations that surround us the whole day. The question is whether we use them or not. Let's start with the technological innovations. We can talk a long time about this, but I took today 5 elements like the patient data management system, the alarms, the safety of the patient, logistics, and ergonomics. These are complex situations, but I go back again to my challenging statement that ICU is a semi-autonomous mini hospital. When you are buying a patient data management system, first rule is actually to buy a system which is primarily eligible to be used in ICU. What most of the hospitals do, the same mistake is done in the hospital that I work in, Utrecht. You buy a system which is eligible to be used in the whole hospital, and you start to try to adopt it to the ICU, which is very, very difficult. While the other way should be done, that a system should be eligible to use in ICU, because what you can use in ICU, you can use in the rest of the hospital as well. Another important issue with the patient data management system is also mentioned by the previous speaker. It should be easing and improving the functioning of the nurse and the physician, and not, on the contrary, causing huge extra burden. I was visiting for accreditation a neighbor hospital about 5 or 6 years ago. They had started with their new system, and suddenly with conversation with the specialists or the trainees, we suddenly realized that they needed more people on the floor because of the patient data management system. Because it was taking so long to work with it. I mean, you should not be using your mouse 20 times to go from point A to B. It must be practical. It must understand the working way of an intensivist and intensive care nurse. If you remember in the old days, and most of us still, as of today, normally the patient has a paper file, but we, on the top of that, we had also these big, wide lists daily where the vital signs and the symptoms of the patient are noticed. It should be compatible with our work form. And the systems are usually like a very, very deep well. Everything you put in is disappearing somewhere in the system. It must be easy also to find it back, to extract information. I just put there as one example for research purposes, but there are many other purposes or analysis of a complications series or whatever. So the extract information is very important. The second important is the noise. It has been mentioned right from the beginning of this webinar. The noise is a very important issue, but as well as false alarms, which cause alarm fatigue by the healthcare workers. If we begin with noise, I have here for you almost 30-year-old publication, which actually shows the decibels, what they are representing, like 40 to 50 a passing car, 10 to 20 rustling leaves. But I have put a special signal there to 65 decibels going all the way to 90. It is representing loud speech and music, or even worse, traffic noise on the main road. And if you look at this old publication, things might have changed nowadays a little bit, but if you have not worked on it, most alarms may reach to 60 to 70 decibel. So our, in some instances, even to 80 decibel. So actually, it's like our patients, family members, and the nurses, physicians, they are just taking care of the patient right in the middle of the highway. So what can we do that? I mean, before that, let's start also to consider how many false alarms that we have. A mechanical ventilator will give an alarm if the patient is coughing. Is that necessary? Because if the coughing stops, then there is nothing wrong there. What is the effect of all these false alarms on the personnel? What happens if you delay alarms? There are publications that the non-vital alarms, when they are delayed something like 10 to 15 seconds, almost 1/4 of the alarms are disappearing by itself. We call them the delayed alarms. We also have the possibilities technologically, and I will come back to that, because having technological possibility does not mean immediate availability. We can also filter the alarms, that the ones that we think which are not vital, again, as I said, the patient coughing for 2 times, or some disconnection of the some parameters, like one electrode while the saturation is going on very normally, they can be filtered. That this is a possibility. You can also synchronize alarms, that your monitor, your mechanical ventilator, giving alarms on actually on the same parameter, that not all 3 of them start giving alarms, but maybe one of them will do that. And of course, the most important ones where people are working on today are the learning of the alarms, that they see the pattern of the patient, how is it developed, what sort of alarms are coming, and what they have a sort of programmed algorithm, by learning it, they will be reducing the alarms. But all of them have one big technical restriction, and I will come back to that in a second. We have the alarm fatigue, when the alarms come unnecessarily, all of them after each other. It can lead to late reaction of the nurses or physicians, or even sometimes to no reaction, because people are used to the fact that they hear all the junk alarms coming. There may be a late reaction there. If we talk about the patient safety, of course, the direct observation of the patient is the real good one, but you need to have the right amount of personnel. You can use cameras. You have to be careful because there is a delay between the image comes to you and what happens in the room. Nowadays, the cameras are much better in quality, so that can be avoided. And of course, we have the medication safety, where the pharmacy has a big role to play. You can have a satellite pharmacy in the ICU, but the medication should be checked by the pharmacist about the doses or interaction. The automated dispensing services are very important, that you can only pick up the medicine that is necessary, that you actually requested. There is no other medicine in that dispenser at that moment, but it doesn't mean that you can give the wrong medicine to the patient. That's why you have to have a barcode scanner right before administering the medicine to the patient in order to check and verify that you are using the right medication. And of course, the nurses can make mistakes while preparing the medication. Ready-to-use medication will solve that problem. The logistics are very important. I will not spend too much time on that. It's a subject of its own. But the issue here is, instead of letting the nurses walk to the storage room to get supplies, to necessary supplies, that they are brought to the patient's room with an accuracy percentage of 95% approximately. And of course, the ergonomics are very important, but the technology is there. They are only quite expensive. The ceiling service units for the keeping the equipment off the floor and flexible positioning of the bed and access to the patient. Now, what I was saying is that the restrictions in technological innovations, especially in the subject of, excuse me, smart alarms, because there is a dependency on medical companies. There is always dependency on medical companies. What I mean by that is, if you are buying a monitor, you buy the whole monitor from one single company. You don't go to company A to buy the arterial pressure module. You don't go to company B to buy the cardiac output module. They are all sold by one single company. Now, however, if you are talking about, for example, the smart alarm systems, there are a series of parties that you have to deal with, and they have to communicate with each other and work together. And that makes it rather challenging, because somebody has to coordinate that, and that there we may have some problems. And the feasibility, I mean, the feasibility in terms of whether we can buy it, it's quite costly, but also, as I said on point one, how feasible is it for the companies to work with it? Like the learning alarms, you need major companies of mechanical ventilators, the monitors, they have to work together, and that is something of a challenge. And the responsibility is a very important issue, because as of today, the industry is actually sending all the alarms to us, and then they say, you just deal with it. And it's not their responsibility anymore, because if there is an alarm, we hear it. So that's how it is. When we try to restrict the alarms, then somebody has to take the responsibility of it in case some adverse event occurs. And that seems to be quite challenging for the companies, rather than sending everything to us. Now, I would like to go back to the natural innovations a little bit. As I said, they are all around us. Most of them, at least, they are all around us. Like the private rooms. We talked about the noise. If you have the private room, you will have much less noise. The alarm will be there if you can't solve it, but the noise is coming all from the personnel or other alarms of other patients and etc. You don't have it. You are private. There is privacy. You are not laying in the middle of everybody. The family support to the patient is better. The nursing support to the patient is better. The communication between the nurse and patient, nurse and family, family and the patient is much better. And of course, the nurse can concentrate much better on the patient. Without being distracted, you can expect decrease in medication errors. The natural light, it's everywhere. The only thing is you have to readjust your ICU if it is possible, of course, or if it is not possible, when you are building a new ICU, you have to take care. Today, there should not be any new ICU being built without the daylight for the patient. I can explain why the agitation and depression of the patient can be reduced by natural light. It is more difficult to explain. These are documented concepts that there is a decrease in length of stay and pain medication, but these are results of certain studies. And also, natural light is extremely good for the well-being of the healthcare workers who are working around there for 8 hours, in some cases for 12 hours. And also a feeling that you are at home, not in an intensive care unit. It's so simple. Put an armchair there, put a lamp there, put a clock there. These are things very natural. They don't cost too much money. And of course, it is mentioned before, unrestricted visiting hours. And I think I have to make one thing clear, because when I say unrestricted visiting hours, people may also understand 24/7 the family sitting next to the patient, and that's not actually that is also a possibility. That's a choice, but that's not actually what I mean. But standard visiting hours of 2 hours block per day, it's killing for the family members, because they have to take permission from their job, they have to rush. There is a huge amount of people, and it needs only a change of mindset to the healthcare workers, nurses and physicians, because they think that people will be walking all around the whole day. It doesn't happen. They just come the moment that they can come, and it gives a lot of satisfaction to the patient and to the family. I said we actually advise them not to stay too long, especially if the patient is getting tired. But if the patient is very ill, maybe dying, there should also be a family stay for the night, so that they are not going too far away from their loved ones. And this is again something very natural, and it doesn't really need any company, any technology at all. The area to rest, area to have some food and refreshments, not only for the families, but also for the personnel. The signage, so that people can find their ways. And the last but not least thing here was actually reported back to us in a questionnaire by the families. What happens is that especially with acute patients, they hear that their family member is in ICU, they just pick up their phone and run. Nobody knows if the phone is charged or not, and they start to call everybody, and in an hour time, the phone is getting empty. So there are possibilities to have small safes with a plug in it that you put your phone, lock it, and take the key. And when an hour later, you just come back and pick up your phone. It gives enormous amount of satisfaction. In conclusion, dear friends, I summarized the innovation as technological and natural. And I would like actually conclude for technological innovation that they are necessary and very important on long term to enable patient care safety and comfort. There are very important determinants for functioning of the healthcare workers if they are chosen properly. And unfortunately, they are mostly dependent on the medical companies who need to take responsibilities to produce them, and that's not the case yet today. And for the natural innovations, they are absolutely necessary for the mental and physical well-being of the patients, the family members, and the healthcare workers. And they are not depending on industrial level, they are dependent on institutional level. And there you need, of course, the backup and the support of the directors of your hospital. Thank you very much for your attention.
Amazing. Professor Joseph, thank you very much. Again, inspiring and a bit provocative. I'm sure you meant it to be like that. So I think we should now move on to the questions. Thank you to all our attendees for posting questions, and please keep posting. So I will start with Professor Delgado, if that is okay. I wanted to ask something similar, but there was a comment in the chat that basically said, not a question, it's a comment. One of the people listening to us was 30 years in ICU and 30 days in ICU and 18 days intubated. And they say that several memories were just dreams, and every day they remember something. And I want to tie this with something that you mentioned in your talk, that we do have evidence that say that up to 40% of our patients will not remember anything, but about 50% of them cannot forget. So I think that is, I think that's very, very interesting, isn't it? And I wonder whether, from all the things you've mentioned, you have something that is, if you could only do one thing, what would you choose to make these memories bearable, I guess?
I'm sorry. Thank you very much for the comment, the question. I think it's very important to focus in the both, in the patients who cannot remember anything. We have the experience in the following of the patients in the discharge of the hospital, now in the pandemic with COVID-19, and it's a reality, more than 50% of the patients only remember the first day when they are conscious attached in the ICU, and after 2 days or 3 days before discharge. And it's the family who remember all the stay. And in this case, it's possible you can think that the patient have not stress factors. But after, a long time after, they begin to remember some things. And this is important to work in this way. And there are patients who remember all when they stay relaxed with deaf sedation, and when you think it's not possible, the patient had remembered anything. And by this reason, every patient is different, and you need to explore with all the patients how is the experience in the ICU. By this reason, I think it's you need to talk with the patient during and after discharge the ICU, because you can improve, and for us, the following of the patients in the extra consults after discharge of hospital has been one of the most right things we can change our practice in the last years. I'm sorry, I can't explain.
No, I think they're difficult. They're difficult questions, aren't they? Because I'm not sure there's an evidently right or the most right thing to do. Joseph, there are a few questions. Gosh, there are a few questions for you, and then I'll go back to Professor Delgado. So there are some questions about the alarms that you mentioned and the alarm limits. So there is a question, I'm not sure if you are aware of this. Are there any official regulations about minimum alarm limits on the devices? Do you know if that exists?
I cannot say with 100% certainty, but if the question is, are there regulations about the restrictions of the alarm? I'm not aware that there are such regulations. What I just wanted to say is that it is the easiest for the industry to produce a machine which actually gives 100% of the alarms. So then it is quite safe for them if something happens, because if we now sit down, and this was something that was the biggest discussion until a couple of years ago, if we sit down with the nurses, physicians, and make a list, which alarms do we want to receive and which alarms do we not want to receive, you see actually that, I don't have it in my mind, the exact figure, but you can reduce the alarms to at least to 1/5 of what we are receiving, maybe even more. But then the question comes, who is going to take the responsibility of this? So once you start to build up such a system, the second thing is to try to get a certification on what you are doing with legal authorities, healthcare authorities, so that there will be a sort of approval in what you have done. Once you have that, any adverse event will not be related to what you have done. I mean, we are not that far yet. We are not that far yet, but you can't just bring together 4 companies and you arrange everything and next day you use it. It has to be certified by governmental organizations. And I'm not aware of a minimum alarm level. All I know is that now is pushed everything to us.
Yes, I think that's interesting. And I was just looking for a minimal alarm level. I couldn't see. And what I saw is that there is definitely not a maximum. There's a minimum one, that they need to be loud enough for you to hear them, but no one says what is loud enough or annoying even. So there is a small follow-up for Joseph and then Professor Delgado. We do have a couple of minutes, I can see. So again, what's your opinion? And it would be nice, because I liked in your presentation, you gave the pros and the cons always. What about the, where is it? Less sound alarms, like your smartwatch that vibrates, for example.
Sorry, I didn't hear. What alarm?
Not audible alarms, but alarms like your watch that vibrate. Do you know anything? Is that a possibility? I can see Professor Delgado.
I think there are a lot of possibilities there. I mean, the sky is the limit. The only thing is, who is going to do it for us? I mean, I've seen, let me tell it this way. There are a lot of hobbyists among us. I mean, we also have 1 or 2 in our hospital. They have enormous intelligence. They know how to do it. But this is not a work of a hobbyist. You must have a professional industry behind you. And that's the biggest challenge, because everything is possible. You can have a vibrator, you can have a screen alarm without any noise. You know, you have a TV screen in front of you, you see the blood pressure alarm. Of course, then the nursing and medical personnel must be changing their sensory systems, because they are now adjusted for noise. They must be getting adjusted to visionary alarms. But the restriction, there is no restriction. What you can hear, you can perform it. The only question is, who is going to do it?
Yes, yes. I agree. Professor Delgado, I don't know if you wanted to come in on this. I do have a question especially for you. So there is in the chat that says, have you conducted, or I guess, are you aware of a prospective trial that would compare, and the intervention arm would be any ICU humanization measure, and placebo would be usual care, and see if there are any favorable effects, and how can you measure them? Because I think I had a similar question. I hear what you say, and intrinsically, it makes sense that, for example, having natural light, like Joseph was saying, or playing music or touching someone's hand would help. But do we have any evidence?
Thank you very much. It's very difficult to investigate in this area because we need to try good outcomes, and it's difficult to change the structure of our ICU. And we try to change different things because all is multifactorial, and I think we need to work in generate clinical evidence about these measures. It's natural, no? It is necessary, but sometimes we need to work in the evidence, because it's evidence in the effectivity and the efficiency of the measures. It's necessary to change not the health professionals, that's all, the managers of the hospitals. And we need to open more investigation about the humanization of the care. It's necessary to change, and it's necessary to change the culture of the healthcare professionals.
Thank you. I agree. And if you could see the chat, it definitely, your talks have generated many comments and interest. And I do hope that means that we're now definitely moving away from just mortality and getting our patients alive, but this, what you both said, that there's something much more than that. So I will thank you both very much for your talks. I will thank our listeners for joining us and putting everything on the chat and the questions on the chat. And I will thank ESICM for organizing this. And I will bid you all a very nice afternoon or morning, wherever you are. Thank you very much. And until next time.
Okay.
Thank you.
Bye-bye.
Bye-bye.